Absolutely. Hey, everyone. Good to see everyone here. And let me see. Oh, there we go. Just wanted to get my full screen. So as advertised, we're going to talk about the treatment of substance use disorders in pregnancy. So I feel like I do this every year. So I've tried to change things up a little bit each year, although the basics kind of stay the same. So sorry if this is repetitive for some of you. I'm going to share my slides. So I'm Laura Lander. Can you see everybody see that?
Yes.
And social work faculty in the Department of Behavioral Medicine and Psychiatry. And I've been here, I was just thinking about this, I've been here for 18 years, which sounds like a really long time. It makes me feel a little bit old. In 2011, we decided to break off the pregnant population and really treat them in their own clinic. We started the pregnancy clinic, Dr. Marshallek and myself. And so I've been specifically working with pregnant women with substance use disorders on their own in a separate clinic since then. I remember we had 3 people in our first group. And what I remember was they were so appreciative of having their own space. And I'm going to really highlight that today about treating pregnant women in all pregnancy groups has become clearer and clearer to me that that is ideal in part because of the stigma that they experience from healthcare providers, from peers, and from themselves. And so I'll share some examples of that. But so always have to talk about the disease of addiction, and specifically that this does not stop just because you get pregnant. And oftentimes people have unrealistic expectations of pregnant women that just because they get pregnant, somehow it should be easier not to use substances, and that is supposed to be a great intervention for the disease of addiction. And while it can help increase people's motivations, many pregnant women I've worked with over the years say, if I hadn't gotten pregnant, I never would have stopped because I would not have done it for myself, but I want to do it for my baby. So it can provide some additional motivation, but it doesn't take away the kind of chronic, pervasive experience of active addiction, which is, related to a disease process in the brain. So just a kind of a specific thing with regard to women, and this can be a review for some of you guys. So women are different than men in terms of their life experiences and this kind of the psychosocial issues that they bring to treatment in addition to biology. So, and this is, when we think about binary gender at this point, we need to be careful. So it depends a little bit on the culture and the family that people grew up in, people's biological sex, and then how they experience themselves. So all of this will go into, what's best for them in treatment. But in general, so if someone was born biologically female, they are actually more likely to come from families with substance use disorders and have a history of over-responsibility, so over-functioning in that family in the context of substance use disorders. And so that often means women put their own needs last, they're less likely to seek treatment. And what the studies show is women are less likely to seek treatment, but more likely to stick in treatment if they don't feel judged or stigmatized. So they actually have better outcomes if they make it there and they're in treatment that treats them from kind of a trauma lens. More likely to be survivors of physical and sexual abuse, as high as 75%. So typically, if I'm working with a female, I will assume that she has a history of physical and sexual trauma, and then we'll sort that out once we get into treatment and she builds a relationship of trust. Very high rates of incest. So when you think about 28 to 53%, very high rates of incest among women who have experienced women with substance use disorders. more likely to have begun using after the traumatic event. So as a way to cope with that traumatic event. So they're very tied together. So as you can imagine, you take the substance away, and often people get flooded with memories and become very, very uncomfortable, whether it be with the feelings they experience, feel their body again, they're no longer numbing, or the memories that they have. So sobriety or getting sober and into abstinence can often be very difficult for those reasons. And then pregnant women with substance use disorders are the most highly stigmatized population, so more so than people who are not pregnant with substance use disorders, and more stigmatized than other kinds of mental health disorders such as schizophrenia or bipolar disorder. So in terms of outcomes, what we know is that if individuals get into substance use disorder treatment, not only decreases active substance use, but it increases their likelihood to seek and attendance at prenatal care. So it often helps them with that fear of being stigmatized. Many patients, the primary reason that pregnant individuals do not seek treatment is because of fear of CPS, whether CPS will be called and intervene with their children who they have because they have older children, or somehow CPS will be called on them while they're pregnant. And so once they enter into treatment, if it's substance use treatment and are reassured that that's not going to happen, they're actually more likely to follow through with OB care. Reduces overdose and death, improves neonatal outcomes, and then decreases rates of co-occurring infectious diseases like HIV and Hep C and infective endocarditis, as well as other infections associated with intravenous use. So the latest numbers we have are really from the National Survey on Drug Use and Health from 2020. They haven't changed a lot with pregnant women specifically in terms of big swings of numbers. Generally, younger women are a little bit more likely to be using substances while pregnant. What we do see is rates of fentanyl increasing and rates of methamphetamines increasing, same as the general population, so no different than that. There's an organization called Project Watch that in West Virginia that does a lot of research on the rates of neonatal abstinence syndrome and intrauterine exposure in West Virginia, and they found that the intrauterine exposure rate among pregnant individuals with substance use disorder is 13.7%, and nationally it's 8%. So it's not quite double the national rate. And then neonatal abstinence rates are much higher. So 5.4% of the general population who delivers babies. But in terms of what that looks like, it's 53.5 babies have neonatal abstinence syndrome per 1,000 births, compared to the national average, which is 6 per 1,000 births, so much, much higher. And what we know is treatment really improves birth outcomes. It improves the outcomes for mother, her experience with child birthing and having an infant, and certainly for all of the neonatal outcomes, such as birth weight, head circumference, and how they do long term. So this is just regionally, because I know lots of you joined from around the state. I had to squeeze these two things onto this slide, so it's a little bit squished looking. But you can see that Region 1, which is the Northern Panhandle, has the highest rates of neonatal abstinence syndrome. So those of you guys who are up there, that's where the rates are the highest. And it has this is really about payer source. So when we look at private pay versus Medicaid, you can see that the rates are much higher among those who are on Medicaid. So poverty really plays a role in this. This is SAMHSA against National Survey on Drug Use and Health data, looking at what substances are more likely to be misuse. So we still see alcohol and tobacco leading the pack, but marijuana is close behind, and these numbers are only rising as it becomes more available and legalized or sold for the auspices of medication. And I actually have, I've been working on looking at some Medicaid data specific to West Virginia. And so the good news is that this is a little bit older data, but and this is specifically Medicaid data, not from all payer sources, but we see opioid use is coming down, and it's significantly coming down. And then creeping up, we see stimulant use disorder. And so we look at what that looks like. It's actually the opioid use disorder over these 4 years decreased by 34%, which is really significant. And stimulant use disorder increased by 86%, even though those bars didn't look really big. It was a significant increase. And that trend has really continued past 2019, as we know. Driven by the methamphetamine use. And when we think about individuals who are pregnant, the symptoms that stimulant use disorder produces can be confusing. And we've seen this recently with the OB providers that we work with, that often individuals with stimulant use disorder are being diagnosed with preeclampsia because that's what stimulant use disorder looks like. It looks like preeclampsia, and it produces the elevated blood pressure that people get really excited about in later stage, the 3rd trimester. There's also an elevated risk of placental abruption, which can be very dangerous in terms of bleeding and needs medical attention. So we worry about, like recently we had a patient who was marginally housed, was not coming in regularly for her prenatal care, was coming into our telehealth program, but she wasn't able to stay because her phone didn't always work, and she was using buprenorphine. We were prescribing buprenorphine, but she was primarily using stimulants. And the concern was that she would try and deliver on her own in a setting that was going to be really dangerous for her, especially if she had something like a placental abruption. Preterm labor is also increased with the use of stimulant use disorder. And what we see in terms of neonatal abstinence syndrome, it looks different when babies are experiencing withdrawal from stimulants versus opioids. Now stands for neonatal opioid withdrawal syndrome, and NAS is really a more general term. And so people are coming to understand what that looks like, which is different than withdrawal from opioids. Babies typically sleep a lot. And as a result, often moms need to be encouraged to wake their baby up to feed the baby, because babies can be underweight, and they really need to eat with great frequency. But if they're sleeping a lot, nobody wants to wake a sleeping baby, so it seems counterintuitive. And yet that's one of the things that we talk about, is you really need to wake the baby up every 3 hours to feed them, even if they're sleeping, especially if they've had some intrauterine exposure to stimulants. So I love working with pregnant women with substance use disorders because they are unique, and they are often really, really highly motivated and know that they want to quit, for their baby, so to speak. And so this has given them a motivation that they have not previously had before. They tend to be a little bit younger, so maybe they've had a shorter progression of the disease process. They've been not using quite as long. They often have family support. If they have a supportive family tends to rally around pregnant individuals, and so they want to be part of a new life, and they have a sense of hope about the future. Again, I've had women say to me explicitly, I really had no hope about my future until I got pregnant, and this has given me hope, and this has allowed me to enter into treatment and see what's possible. So they can have that higher level of willingness. Some challenges are often high rates of intimate partner violence. And when I started working with pregnant women, it seems to increase I don't know the stats on it, but it actually seems to increase when women get pregnant, that the intimate partner violence doesn't go down because, oh, you're pregnant, I'm not going to engage in abusive behavior, but it actually increases. Very high levels of guilt and shame. So that's what, even if the individual is not talking about it, they no doubt have it. Women have it, especially if they are scared to come into treatment and don't come in until later in their pregnancy. They have tremendous amounts of guilt and shame. Often women who are using substances don't have regular periods, so they don't know that they're pregnant until the 6th month, and then they feel terrible about having used during the early stages of their pregnancy. They have childcare issues, childcare stresses, making it hard to come in for treatment in terms of who's going to watch the kids while I go to treatment, transportation issues, employment and financial issues, and are at risk for medical complications. And as I said before, experience high levels of stigma among their family as well. So healthcare providers stigma, community stigma, self-stigma, and then often their family members are very stigmatizing, including about medication for opioid use disorder, if that's what they're choosing in terms of their treatment. And it's really the biggest barrier to seeking treatment is what they'll say. So there's a phase called the 4th trimester, which is actually after you have the baby. And this is a really, really high risk time, high risk for dropout from treatment. So if someone came in and the primary motivation was for the pregnancy, and then the pregnancy is no longer there after the baby is born, often individuals will relapse at this time. And it's scary because they're obviously caring for an infant if the infant went home with them. Postpartum anxiety and depression. So we know that our patient population has higher rates of postpartum anxiety and depression. We want to be screening for that regularly and talking about it, because oftentimes they know about screenings and they won't answer the questions necessarily that's going to give them a positive on a screen. So finding other ways to have those conversations about how they're feeling is important. There are often negative family interactions that can sometimes be related to CPS involvement or not, but there can be negative family interactions because having a baby is stressful, and everybody, our culture tells us you're supposed to be happy and it's supposed to be wonderful, and actually it's really stressful. And so there's sort of this additional layer of guilt and shame on families, mothers and fathers, about, why aren't you happy? You have this beautiful baby. It's like, I'm happy, but I'm also stressed out and exhausted. And for the individual with the substance use disorder, feeling guilt and shame. And then the risk of neonatal abstinence syndrome. Sometimes babies have to stay in the hospital and be treated for neonatal abstinence syndrome, or if the baby is preterm, stay in the NICU. And we know that that can really have an effect on maternal-child bonding. So whenever possible, if mom and baby can stay together, that's wonderful. And as much as family members, parents can visit the baby, certainly the best for continuing that bonding process. So this was a study done in 2018 in Massachusetts that actually had pretty alarming overdose rates, showed alarming overdose rates among both pregnant and postpartum women. So again, after pregnancy is a high risk for return to use, including overdose. So into treatment. You guys are familiar with all these kinds of treatment options during pregnancy. Detox is not recommended by ACOG. It's not that it cannot be done safely in terms of the baby being monitored and nothing bad happening in terms of the birth outcomes for the baby, but we know that generally after detox, unless people are followed very closely and have pretty intensive treatment, the majority of people relapse, especially after detox from opioids. So it's recommended that in pregnancy, that if it's opioid use disorder, that a medication be prescribed. So group is really the treatment of choice, not only for substance use disorders, but for pregnant women with substance use disorders. What I have seen over the years is they're able to support each other like no other people can support them, because there's really often very little judgment. I have a patient in my group right now who she came into treatment and she was not able to discontinue methamphetamine use, and she didn't use opioids at all. She was on buprenorphine, but she used methamphetamines throughout her pregnancy. And every new person that comes into group, she says this too. And she says, don't judge yourself. I was not able to stop using methamphetamines during pregnancy. You know, the disease doesn't go away just because you're pregnant. You're in treatment now. She's so supportive. She does like a whole spiel for new people. I love it. Like, I want her to stay in the weekly group forever, because she right off the bat just conveys like you're in the right place, and you can only change moving forward. And you're not the only one, which can be really, really powerful for people experiencing tremendous guilt and shame. So general interventions, contingency management, relapse prevention, motivational interviewing, and CBT generally are what we use, and always a trauma-informed approach, because we want to assume that pregnant individuals coming into treatment have a trauma history. Whether they're talking about it or not, they likely have it. Really common issues that we talk about almost every week are domestic violence or relationship issues with partners, CPS issues, and also parenting. So sometimes people have children, and so parenting and integrating a new baby into the home is often a topic of conversation in therapy groups, and also effective parenting with a newborn, and really understanding the developmental stages and what to expect, what kind of behaviors you can expect, so the thing that people say is, oh, you're spoiling that baby, right? You cannot spoil a newborn infant. You're really, when you respond to their cues and when you hold them, you're teaching them about the world being safe. And so, but often they get messages from their families about, oh, you hold that baby too much, you're spoiling it, and you hear that a lot. And so helping them really understand developmentally what is happening with their babies can be really helpful if they're getting other kinds of messages from their families. I always talk about relapse, and there's tremendous guilt and shame about relapse if people are pregnant or even postpartum and they beat themselves up a lot. We've seen people drop out of treatment because they're afraid to come back and talk about a relapse. There's so much guilt and shame. And so really, not that relapse is a requirement, but a relapse or a recurrence can be part of treatment, and people can learn tremendous amount from it, from the experience. It can also be scary because there's always a risk of overdose and death as well. But awareness of triggers, and we talk about issues of cross addiction, which is why we generally don't allow use of other substances, and then really talk about co-occurring mental health disorders, and that those can be a trigger for relapse. So the importance of treating both. So you guys probably have know all of these options: methadone, buprenorphine, and then Sublocade and Brixadi. So Sublocade and Brixadi have not been approved for use in pregnancy. They are under study. Brixadi, I know, is under study through the NIDA-CTN. Currently, it may be approved eventually. There are some folks there's some prescribers who do prescribe in pregnancy if the risks really outweigh the gains, because some people are not able to keep medication safe or take medication safely. There's also some promise in terms of using naltrexone in pregnancy, but it's also not FDA approved. And then Vivitrol being the long-acting substance. So all of these are potential options. Obviously, most of you are familiar with buprenorphine and methadone, and the general benefits outweighing the risks. So this is just kind of looking at those two lists, because we get certainly partners of pregnant individuals and family members will say, why would you take that medicine? That's just trading one drug for another. We hear that all the time. And these are often the benefits that we talk with the individual about, or we can even offer to talk to their family members about that if it seems appropriate. And always a plug for breastfeeding. Breastfeeding is recommended by both ACOG and the World Health Organization, even for individuals who are on medication for opioid use disorder, as long as they're not using other substances for these reasons. Many people have questions about that still. Even we've had medical residents tell our patients you cannot breastfeed, which makes me crazy. So I can make sure to repeat this. And then I'm going to talk a little bit about integrated care. I just wanted to answer any questions that anybody might have so far. I don't know if there were any in the chat.
Laura, can I ask a question?
Sure.
So I was just kind of thinking on the point that you've made of kind of coming into the care model with the assumption that the patient has had a history of trauma. But with the patients that are not yet ready to discuss trauma or disclose trauma or get into any of that, wouldn't that practitioner's kind of assumption of that hurt the therapeutic relationship, or no?
So the way that the way that we talk with people, the way if we have any control over our physical environment, so those are all things you can do with the assumption that people have experienced trauma. So at Chestnut Ridge Center, I do not control the fact that the first thing people see is a security guard, and they have to go through a scanning machine. However, in my office, I try and have my chairs so that nobody would ever have their back to the door, have sort of a calm and soothing environment, those sorts of things we can control. And when we think about the birthing process, how do you do trauma-informed birthing stuff? So I know that Kelly Lemon talks with her OB folks a lot about this. So being held down is something we would try and avoid at all costs. Especially, just assume that that's not going to be good for anyone, especially an individual who has a trauma history. And the way that you touch people, because upon physical exam, we have to touch people. So it's always best to ask before you touch someone, is it okay if I do this? So things like that is what I mean by a trauma-informed approach versus asking specifically about, have you ever had a sexual assault, been sexually assaulted?
Thank you so much. Yeah, no, absolutely. I totally wasn't even thinking in most of the realms that you just described. So thank you.
Okay. Any other thoughts or questions? So I'm going to talk a little bit about our integrated care model, which we used to call centering, but because we're not in person anymore, we can't really do proper centering, which is where you would really co-locate, in this case, OB care and hands-on, where you can touch people, OB care, and medication for opioid use disorder. So in our model, our nurse midwife is our prescriber, so she can ask all kinds of OB-related questions while she's also prescribing medication for opioid use disorder and checking in with people about their recovery progress. So we have weekly med management groups, random urine drug screens, strip counts, all of these normal things that you guys are familiar with. And with the green things are really what's emphasized in PCOTE, which is pregnancy coat, but it really is pregnancy and postpartum coat. We require individual therapy specifically because of the trauma history that most women have, and they may not be ready to get into that in group. And we can get a better sense of their readiness in individual. Not that they may be ready in individual either, but at least we can have a sense of the role that may play in their recovery, in terms of, at the very least, any triggers for recurrence. They have peer recovery support through our ACE program, and Candy Cooley is our peer in our. She comes to both group, and then she has a Zoom group for the women in the ACE program. That's not treatment; it's really a support group, and that's outside of treatment, which is really nice because it's less structured, and they can really talk about anything. We discuss birth control regularly. And it's worth talking about in pregnancy because oftentimes people, if they are prepared, they can elect to have a long-acting kind of contraceptive at the time of delivery when they're in the hospital. And so they don't have to come in for a separate appointment. And we know sometimes people don't come in for a separate appointment. So it's really important to discuss this during pregnancy when they are coming in, hopefully, to see providers regularly. There's really an emphasis on retention in treatment. One of the ways that our P code is a little bit different than regular code is we probably are not quite as stringent about referring people to a higher level of care if they're refusing. I mean, we always refer them, but we will let them stay in care with us until they deliver and not sort of force anybody into a higher level of care because of the concern about the pregnancy. So it's a little bit of a harm reduction approach, like better to have someone in treatment and actively using than not in treatment and actively using. I don't know if my team would agree with that statement 100%, but that's really my philosophy, is that we really want to have them continue to come to their OB visits and come to see us, even if they're not able to acquire sustained abstinence. And then once they have the baby, they are able to move on. And if they have over 90 days of sobriety, they move on to our biweekly group and eventually our monthly boot group. And those are very postpartum and parenting focused. And they can stay in PCOT forever. So as long as they want to be on medication, we actually had someone stay for a year after she tapered off medication because she liked the support of the group so much. So she didn't really do much with the medication management part, but she still wanted to come to the group therapy part because she had been with those women for a year or more, and she really felt supported by the group. I know we have people in our monthly group who have been coming. I know for 7 years, and they're just maintained on medication, and they really enjoy coming to the group and providing support for one another and receiving it as well. So this is a little bit about ACE. ACE is a program that's funded through the Perinatal Partnership and also SAMHSA and DHHR. So we started in 2012 with 4 sites, and now there's 17 sites, and these are really embedded peer recovery support specialists and support folks. They're embedded in OB settings, so in the hospital setting, and they can help with resources and support and referral to treatment. And our ACE coordinator, they have a baby pantry. So if people say, "Oh my God, I don't have a baby gate," or "I don't have plugs to put in the wall," or "I don't have diapers," they can, or even a breast pump, they help get all kinds of things that people need to be ready to have a baby. And they also provide peer recovery coaching through that. So you guys probably know the answer to this. What's the answer to this question? Anybody know?
I might be wrong, but transportation?
Transportation is one, but I don't think it's the biggest one. Somebody else said
stigma.
Yes, absolutely. And stigma is really influenced by our thinking. So how do we think about the cause of and how controllable substance use disorders are? And so if you believe that this is a disease, that's going to decrease stigma. If you believe that this is a choice, that's going to increase stigma. and what you believe about people's control and ability to control having the disease or their active use. And so healthcare professionals are really, we are in a really important space to be able to do something about stigma. Welcoming patients in. I'll never forget early on when we sort of developed this pregnancy clinic and we started doing intake specific to pregnant women, the number of women I had that said to me, "Thank you for being so nice to me." And I was not, I was just welcoming them into treatment and not being stigmatizing. And they would like cry. I mean, it was really, really both touching and horrifying that, a lot of times they'll go into spaces and right off the bat, you'd be judged either for being pregnant and being on medication for opioid use disorder, or being pregnant and having a substance use disorder. And they will say they can feel the change in their provider the minute they find out that is the case.
Sorry. I'm gonna send you the screen.
So, and we can educate colleagues, so educating our OB colleagues if we're working with pregnant individuals about is it brain disease, about control and about cause and controllability. Sharing stories of success is really important because oftentimes, say, our colleagues in the ED do not see a lot of people who are successful in recovery because they only see the people who are struggling. Utilizing peer recovery support specialists I have found really, really helpful in reducing stigma, both like at all levels, like institutional, healthcare, and even self-stigma. Using non-stigmatizing language, which I think we've gotten much better about. Being aware of our own biases. So it is not easy to think about the impact of a pregnant individual using substances, and then we imagine, the fetus and what that's doing to the fetus. Like, it is not easy to have compassion if we're having a whole bunch of focus on like the damage that's being done. And so just being aware that this is not, an easy population to work with, and compassion is going to be the key to keeping them in treatment. And shaming them, or why didn't you come into treatment sooner? The individual's already doing that to themselves. We don't need to ask that question. They're already kind of judging themselves around that. And that includes around relapse. So really, I approach relapse or recurrence from a place of learning. What can we learn? What did you learn? What are other people able to learn so they don't have to experience it themselves? And then finding support for our own transference if that gets kicked up. So I have a video, and I'm going to do my best effort to make this work. It worked when I tested it. There you go. And these are some women talking about their experiences as pregnant women with substance use disorders.
I started using drugs when I was 19. I was introduced to them by a boyfriend. From 19 on, I used pretty much anything I could get my hands on up until I was arrested. And when I was arrested, I discovered I was pregnant.
My path to addiction probably started a little later in my life. I went to college, I went to school, graduated top of my class, had a good career, and I didn't start using until I was 29.
So I was scared, like I was worried there was going to be something wrong with my baby. I was wanting all the medical care I could get, and like I just wasn't getting it.
And then I found out that I was pregnant. I knew that I had to do something, but I just had such trouble getting help.
Or waiting on the ambulance to get there. And his supervisor came over the phone and he was like, "Is that pregnant idiot still back there? Or has the ambulance come and picked her up yet?" Whether you're clean or not, you're kind of always labeled a drug addict. really hard.
I didn't say anything to the doctors because I was afraid of the consequences. I thought they would take my baby. My family would find out. It just, the stakes seemed so high. But I was like, I knew I had to do something before he was born. So I go in, I do the assessment. She didn't make eye contact or look at me the whole time.
I was judged more harshly. And you can usually see it on their face by being called junkies and just like addicts. Like it's just a dirty term.
Think of it person first and not I'm an addict, but a person with an addiction, just like a person with an affliction. And I think that would help with the stigma.
I mean, we're people just like everybody else. And I think labels like that, they really are dehumanizing. It makes you feel like less than people.
You know, addiction doesn't have any creed or any discrimination. It's a disease just like diabetes. It's not anything that you do purposefully.
One thing I think healthcare providers could do to help encourage people coming in to get help is just to remain professional. Treat us just like you would any other patient, especially if they're there to get help. Because being judgmental and stuff like that, we can see it. We're not blind. We can see whenever you're judging us for something like that. And it'll keep us from seeking help.
I would say the difference between the facilities versus here is vastly different. Like I didn't feel like I was in trouble or being criminalized. They asked me what I needed, what my goals were, what my son needed.
And when I see him smiling, laughing, playing, it gives me hope for the future that I'm going to be able to hold on to this and get clean. And I think I'm actually going to make it this time.
So that's a video created by Andre Jones and some of the folks at University of South Carolina. So just to summarize, pregnancy does not cure substance use disorders. And so sometimes even patients will feel like, oh, well, I'm pregnant, I should be able to stop. And it's like, well, it doesn't change it from being a chronic brain disease. And some of the most important things that we can do is conveying compassion, recognizing our own biases, using non-stigmatizing language, understanding that intersection of trauma and addiction and treating both, and then really recognizing addiction as a chronic relapsing brain disease. And if someone does have a reoccurrence, to address it as a potential learning experience and part of their recovery versus just being shaming or critical. I think that's it.
Thank you so much, Laura. Thank you so much for including that video. I'm glad it worked for us because that's very impactful to see it from their perspective too, and hearing them, and that was tough. But appreciate it and thank you very much. Does anybody have any comments, questions?
Or cases, I don't know.
Yeah. Experiences that you'd like to share?
I'd just like to say congratulations. Laura got an award this past weekend at the Addiction Medicine Conference, so congratulations.
Oh, thank you. I was super sad. I go every year, and this year I was at a different conference, which I had not clearly, I don't know if I hadn't realized it overlapped with the same date, and then I felt, I don't like it when people get an award and they don't even show up for the conference, but thank you very much. I appreciate that.
You're welcome.
A lot of people are saying congratulations in the chat, and congratulations. That's excellent, Laura.
Yeah, I mean, I will just say that working with pregnant individuals in the group setting is incredibly rewarding because the kind of support they offer to each other is really special because they're all sort of going through this thing together. And because it can feel like us against the world, that I think it increases that bond between them, and to kind of bear witness to that has been wonderful. And I'm so glad we created the separate space for them, because what we did see in a mixed gender group or a group even with non-pregnant individuals, although it was a little bit less harsh with other women was if they had a hard time saying that they relapsed, even more so than usual. And they were definitely judged by their peers if they had a recurrence and were pregnant, and you could just see it in the group, and that felt really not helpful. And we would do education and we provide support, but you know, people didn't even need to say anything. They could feel the room. The other thing that I didn't talk about explicitly in here was just developing a good relationship with whoever the OB provider, the service nearest you might be, is really helpful. We've been able to do a lot of education around stigma, and yet even given that, it feels like there's always more we can do, just because, you know, the nurses that work in the NICU have very strong feelings about individuals who use substances while they're pregnant. And so, because they are very focused on the babies, and they do get into some blame. And so to help them both tolerate the difficult job that they have, and also not blame the mother is really important.
Thank you very much. Well, if there aren't any questions or comments, we will just go ahead. I'll just make that final announcement. But please send any questions if you do have any that come to mind, and always know that you can submit cases. We'd love to get some. It's been some time. It doesn't need to be too complicated. It can be just a question too. It just gets us closer to that echo. That
Do
we
you want
want
to present a case? Because I have a case. Do you want to present a case?
Yeah, that's fine. Absolutely.
Actually, we have a case that well, an individual who recently delivered, and it was a little bit hard for me because she came in late stage, and it's unclear why she came in late stage, although I assume because she was afraid. And she said she didn't know she was pregnant, which is also quite possible. She's marginally housed, so she's kind of staying with friends, doesn't really have stable housing. And she was coming not consistently, let's just say. So we were trying to get her into prenatal care. She finally went to her visit. She didn't like the provider. She felt judged. She said, I'm not going back to that provider. We were like, absolutely fine. Let's set you up with someone else. And she did not go. I think she was afraid of being judged again. She would kind of show up sometimes, not show up other times, which can be frustrating for the team because they're like, is this person okay? She's not in prenatal care. She's not coming in for her urine drug screen. We don't really know what's going on with her. And so it was a dilemma about, do we discharge her or not? Because she's not really adhering to weekly visits. And I was trying to get her in for individual therapy, and she no-showed her individual therapy. And so we were making all of these efforts. And then it was interesting. About a week before she delivered, she never did come to see me for individual therapy, but we began to have this, we have an electronic medical record called Epic, and patients can message back and forth on Epic. And we really had several conversations on Epic. And it occurred to me that I perhaps could have started that sooner. Like, you never know who's going to want to have a connection that way. And I guess I didn't realize that she would be one of those people who really wants to have a connection via electronic medical record. And that, to me, probably speaks about her anxiety and her fear of being judged. And we had multiple conversations on Epic, and I hope to actually be able to. She just delivered today or last night. And so I hope that she will stick around. And maybe it was just that she was not feeling like she was trusting us and the connection. And then she had that bad experience with the OB care. She wasn't really feeling connected to others in groups. She hadn't reached out to our peer recovery coach, but we tried our best to retain her. in treatment, even though she wasn't entirely adherent. So being creative and trying different ways, just a reminder for me to try different ways to get connected to people, whatever is at our disposal. Oh, and she was very proud of herself. She didn't need an epidural. It was really cute. Not that there's anything wrong with an epidural. I had an epidural, but you know, there was something that she wanted to share with me that she thought that was a really good thing for her.
Thank you so much for sharing. It's awesome. Does anybody have any comments or questions? Please feel free to unmute.
Or any cases, you know, any pregnant individuals that you're working with, and thoughts about them.
If the mom stays in group for a bit after she's given birth, what kind of resources exist for like the baby if the baby needs any additional care or like financial situations, etc.?
So we always encourage moms to get set up with Birth to 3. So that's like a home visiting service that will help. They help teach moms about kind of the developmental stages. They also can kind of keep an eye on birth weight and any struggles mom's having with attunement or attachment, or any questions that mom has, or dad, the whole family can ask questions. So Birth to 3 is a great resource. And then Birth to 3 is almost like a wraparound service in and of itself. So they can connect them with other resources as well, which is why, I love Birth to 3. I know in Morgantown, there's also the Happy Project, which is also kind of a visiting service as well. I assume other people are familiar with ACE, with the ACE program. That's another service that provides other resources. So the ACE program is at 17 different hospitals all over the state, and their care coordinators can connect people with, say, if they're struggling to buy baby clothes, they can connect them with resources for whatever they need, or bottles, or whatever you need for the newborn.
Thank you.
Sure.
Laura, this is Jennifer Boyd. I have a question. It's always helpful to hear you talk, and thank you for this. I learned a lot today. My question is about pain management during the delivery, especially you mentioned your patient in the epidural, and I really have only ever had one pregnant patient in the practice, and that was a long time ago, and she left to go to another state. But do you guys do any coordination with the OBs about pain management, and do they usually just continue the patient on the Suboxone? Is there any indication to increase the dose of Suboxone? How does that? I don't really know anything about how that works.
Yeah, so Kelly Lemon did an echo today on pain management in pregnancy. So I don't know, Elizabeth, if that can be sent out to people. I don't know how that works. So there are all kinds of non-medicinal strategies for relieving during pregnancy, cramping, cramps in your legs, back pain, abdominal pain, all kinds of strategies that she went over. So that should be posted to YouTube, right, Elizabeth?
Yes, it should be, definitely.
Okay. So I don't know how do people find that?
Just by going to the YouTube page. So even if you get the link from us, you can go to our actual YouTube page, click videos, and I'll do the most recent videos that way whenever we do the send out the post email.
Yeah, so I encourage you to watch that. But the other thing is, we used to tell people to come off their buprenorphine before delivering. We no longer do that because that was a mistake, we have learned. So people remain on their, if they're on medication for opioid use disorder, they remain on methadone or buprenorphine, and then the SAMHSA recommendation is that you actually treat with short-acting opioids any pain. What we do here typically is if they're on buprenorphine is to give them a little bit of extra buprenorphine to treat any pain, like we would with like a tooth extraction or something like that. And they can get opioid-based pain medication in the epidural. So buprenorphine does not block that. So fentanyl is sometimes given in the epidural. And then, of course, I'm going to forget the name of what's the other medication that's given in the epidural? It begins with an E. Oh my gosh. It's in the video. I can't remember.
I don't know either. Very well.
So it's the only caveat to that is it's really, really, really important to document that in the chart. And if CPS is going to be involved, the baby will test positive for opioids or for fentanyl, and to just do really, really clear documentation, or we can, as providers, we can provide that documentation. This individual was given pain medicine in the hospital, because if CPS becomes involved, we've had cases where CPS tries to say, oh, they were positive for fentanyl. It's like, no, we had the urine before and then we had the urine after, and we have documentation that we administered fentanyl as part of the birthing process. So that's the only caveat to that.
Okay, great. Thank you.
Sure.
Great questions. Thank you so much. All right. I'll go ahead and make that final announcement, everyone. Again, thank you very much. And the next time we'll meet will be on October 23rd with Katie discussing standards of practice. So again, thanks guys, and hope you have a great rest of your day.
All right. Have a good night.